Thank you, especially to Gyan sir and Sava sir for giving me this opportunity here. So, before we move on to the newer imaging modalities, I believe a quick revision of the conventional ultrasound is always important. So, a quick go on the normal anatomy of the thyroid. This is the butterfly-shaped gland with strap muscles in the front. Posteriorly, we have trachea. On the left, we have esophagus and the longus colli muscles posteriorly. Bilaterally, we have the IJV and carotid vessels. So the basic features which discriminate between the benign and malignant nodules. The benign nodules mostly are purely cystic or cystic with thin septa. Malignant ones are mostly mixed solid and cystic. If the nodule is hyperechoic, more echogenicity, then it is probably benign. If it goes towards darker side, it is more malignant. Then the well-defined margins, big calcifications point towards benignity, and malignancies by microcalcifications, the punctate echogenic foci, they are more towards the malignant side. So quickly, the conventional ultrasonographic features. This is the spongiform pattern, very typical of a benign nodule. This is a solid nodule with less than 5% of the cystic areas, so more towards the malignancy. And the ones in which there is peripheral thick rand of soft tissue, there are more chances of being malignant. Echogenicity wise, if the nodule is hyperechoic, then it is benign. And as it goes more and more hypoechoic, like this one, where the nodule is quite dark, it is more towards the malignant side. Shape wise, if the nodule is taller than wider, it is more of malignant, and if it is oval, that is wider than tall, it is benign. Then margins, if the margins are very smooth, well defined, it is more towards the benign side. If it becomes lobulated or irregular like this one, then it is more towards the malignant side. When there is extrathyroidal extension, the chances of malignancy increases. Then the echogenic foci. So normal thyroid also has a speckled pattern, so it should not be confused. Like this one is a speckled pattern. However, the microcalcifications like this, which give the short comet tail, these are very highly likely of the malignancy. And the larger coarse calcifications, they are more in the benign nodules. So by combining all these things, we can classify the nodule according to TIRADS. And by TIRAD score, the follow-up is done through FNAC. So what's new now? We'll talk about that. CT and MRI are done for thyroid diseases to look for incidental nodules, locally invasive diseases, lymph node metastasis, any post-treatment recurrence. And new things are coming up now, like multiparametric MRI. So it was noticed that with the conventional ultrasound TIRADs, they had a lot of unnecessary biopsies, unnecessary FNACs were done because the specificity was only 49%. So new things are coming up now to reduce the rate of unnecessary tissue diagnosis. And so diffusion weighted imaging is one of those. And we know that when the nodule becomes more and more malignant, the cell density increases. And as the cell density increases in tumor tissues, the water diffusivity decreases. So these malignant nodules with high cell density, they light up on the diffusion imaging. Like we can see here, this is a nodule on conventional ultrasound, and on diffusion weighted imaging, it is lighting up. However, to confirm that this is restricted diffusion, we need the ADC imaging on which it should appear black. If the nodule is is lighting up on the diffusion, but it is not dark on the ADC images, it is not a true diffusion restriction. So that should be taken care of. It should be a true diffusion restriction to label the nodule as malignant. Now, besides the conventional ultrasound, elastography is coming up. So elastography can be used to upgrade the conventional ultrasound imaging, and it can be a valuable tool in the indeterminate nodules, Bethesda 3 and 4. In finding out localizing small papillary thyroid carcinomas. The papillary thyroid carcinomas have very fibrous stroma, so they are very stiff, and elastography can help to detect the papillary thyroid lesions. Also, the lymph node metastasis of PTC. The lymph nodes also have very tight fibrous stroma, so they will be very stiff on the elastography and they can be picked very easily. Similarly, recurrent disease assessment, scar versus tumor. So scar is also stiff and tumor is also stiff. However, scar is homogeneously stiff and tumor has mixed areas of necrosis and scarring. So the homogeneity will differentiate between the scar and tumor. There is this RAGO criteria. It will be more clear with this image. So usually all the machine vendors, they set this format. It can be reversed, but usually the green represents the elasticity and the blue represents the stiffness. So in the first image, you can see that the entire nodule is green. That means it is very soft. So it should be a benign nodule. In the other image, we can see that there is some areas of stiff areas, and as the grading increases, the stiffness, the blue areas increases. Like in the last one, the entire nodule is blue in color. So that means it is very stiff and it can be used to confirm malignancy. However, there are some pitfalls to elastography, like if the nodule has a calcified, peripheral calcified shell, we cannot use elastography. Intralesional calcification, large calcifications, they also will be very stiff. And although coarse calcification are seen in benign nodules, still we can get the stiff, because of the calcifications, the nodules will appear stiff on elastography and it will be a false positive. Similarly, partially cystic character also alters the nodule elasticity, and the Hashimoto's thyroiditis, Reader's thyroiditis, all these things which although they are benign, but because of the fibrosis, they are very stiff and they can give us false positives. Then another new thing that is coming up is the contrast enhanced ultrasound. So we know about contrast MRI, we know about contrast CT. Now contrast can be done even in the ultrasound. And the good thing about the ultrasound contrast is it is not at all renal toxic. It can be given at any creat level, any GFR level, and also it is non-ionizing. So it can be repeated multiple number of times, and it is excreted via lungs. So there is nothing to worry about except the cost. It is slightly costly in India. One vial costs around rupees 6,000. So where can we use contrast enhanced ultrasound? In adjunct to the conventional ultrasound. So again, the indeterminate nodules with HISDA 3 and 4, nodules with indeterminate conventional findings like TIRETS 3 and 4, and to differentiate between the follicular adenoma and carcinoma, which always remains doubtful for conventional ultrasound. And also like post-ablation, to determine whether any viable thyroid is left after ablation or not, we can use the contrast enhanced ultrasound imaging on table. So how is it performed? It is performed on the same machine that we have, the routine ultrasound machine. The settings are changed to low mechanical index, and intravenous injection of the contrast agent is done. Within 2 to 3 minutes, the thyroid gland lights up, and based on the enhancement patterns, we can determine whether the nodule is benign or malignant. So what all we look for, the enhancement pattern, we look whether the nodule is enhancing homogeneously or heterogeneously, whether there is peripheral enhancement is smooth or it is irregular. So irregular central enhancement is strongly associated with malignancy, whereas homogeneous enhancement and smooth peripheral enhancement suggests benign nodules. And the degree of enhancement also suggests whether the nodule can be benign or malignant. Like because of the abnormal angiogenesis, the malignant nodules, they enhance slightly less on the contrast enhanced ultrasound. It is different than the contrast enhanced CT and MRI. So also the wash-in time, if the nodules have slow wash-in time, it indicates malignant nodules, and if there is persistent contrast, it suggests malignancy. So to summarize, if there is homogeneous hyper iso or no enhancement, and there is a regular high enhancement ring in the periphery, they are mostly benign. And if the lesion is showing iso enhancement with focal areas of low enhancement, it should be considered malignant. And an irregular ring in the periphery also suggests malignancy. It will be more clear with these images. So this is a conventional ultrasound which with a hyperechoic module. And on contrast enhanced ultrasound, there is very homogeneous enhancement with a very smooth peripherally enhancing ring. We can see here. So this is a typical of a benign nodule. Again, in this nodule, we can see that this appears more of a solid nodule which is hypoechoic. So on conventional ultrasound, we may get confused that this is a malignant nodule because it is hypoechoic. So thyroid score will increase, and it is completely solid. So the thyroid score is definitely going to increase, and we'll unnecessarily put this nodule for FNEC or biopsy. However, on contrast enhanced ultrasound, we can see that it is not enhancing at all. So that means that the central part is non-viable. And this was a benign cystic thyroid nodule with hemorrhage within. So with the help of contrast enhanced ultrasound, we can actually downgrade the ACR thyroid's level and prevent the unnecessary FNACs. Like this nodule, it is hypoechoic on ultrasound, and on contrast enhanced ultrasound, we can see that there is heterogeneous enhancement. These are areas of iso enhancement, some areas of no enhancement, and the margins are not clear. So this points towards malignancy. And the another very good role of contrast enhanced ultrasound is during ablation. While doing the microwave ablation on table, we can determine that how much part of the nodule is still left during ablation, how much part is a viable part, what is the normal thyroid gland, so with the help of contrast enhanced ultrasound, we can reduce intraoperative bleeding and minimize damage to the thyroid function. Similarly, for follow-up also, this contrast enhanced ultrasound is very good. Instead of doing repeat CT, repeat MRI, giving renal toxic contrast agent, we can always do contrast enhanced ultrasound, and we can see how beautifully we can see that whether the ablation is complete or not. On conventional ultrasound, we may feel that a viable part is left. However, when we give the contrast, we can see that there is no viable tissue and it is a complete black hole, which makes us confident that the ablation is complete. Thank you so much.